Hello everyone. Today I am going to discuss about renal replacement therapy in the ICU and myself Dr. Vikram Gupta. I am professor in Department of Anesthesiology, Institute of Medical Sciences, Banaras University, Varanasi. And as we all know that this topic is very important to discuss because the incidence of AKI in critical patient is increasing and it has very high morbidity, mortality, and there will be long-term risks of chronic kidney disease. This is joint venture of both nephrologist as well as intensivist, and better team collaboration is always required to bring out the best outcome of such patients. Nowadays, we are following this KDIGO classification to define acute kidney injury. Before that, rifle and Akin criteria was used for the definition of AKI, but some shortcomings in those criteria that will be addressed in this KDIGO classification. And they have divided the AKI in three different stages: stage 1, stage 2, and stage 3, on the basis of value of serum creatinine or changing trends of the urine output. This diagram in the horizontal axis showing the different stage of development of acute kidney injury from left to right and the recovery from right to left. So this yellow one showing the normal patient or patient those are at risk like diabetic, hypertensive patients or many more. And when such patient has some insult like sepsis, dehydration, gastroenteritis, exposed to the nephrotoxic drug, then there will be certain kidney damage in the kidney. And how will you define this kidney damage is not yet defined. But yes, you can diagnose on the basis of early biomarkers such as neutrophil gelatinase associate lipocalin, kidney injury molecule 1, interleukin 8. Because on the basis of serum creatinine and urine output, we can't diagnose the urine damaged part of the kidney because serum creatinine will take to rise time. It will take to time to rise. It is the late marker, varied production of the serum creatinine, and many more. And after the damage, there will be a decreased GFR, then patient kidney become failed, and ultimately patient develop a lot of complications related to the ongoing inflammatory process and organ crosstalks, and patient will die because of the complications of the AKI. This decreased GFR and kidney failure can be diagnosed on the basis of creatinine and urine output level as discussed in the KDIGO classification. So death from AKI is from the complication of the AKI, and this study has been published in Clinical Journal of American Society of Nephrology by Livorio et al. And this diagram, that is the multivariate logistic regression analysis, showing that the excess hospital mortality in AKI patient is mainly because of the fluid overload when it is more than 5%, hyperkalemia, and the metabolic acidosis. See the burden of this disease. This is the AKI EP studies, epidemiological studies, done over 33 countries, included 1800 patients almost, collected data from 97 ICU, and all the data is collected within 1 week of the ICU admission, as it is the cross-sectional studies. And 57.3% patient, more than 1000 patient develop acute kidney injury. And see the incidence of stage 3 is 30%. They found the most common etiology of AKI in critical ill patient is first one is the sepsis and second is the hypovolemia. And what they concluded? The mortality is very high, those patients who develop the AKI. Increased length of stay in ICU as well as hospital, and discharge with the increased serum creatinine level. And they see here the mortality adjusted odd ratio in stage 3 is 6.884, significant. There is no nationwide data for the incidence of AKI in the critical patient in our country. But yes, we have some fragmented data from the single center, but there are a lot of fallacy. They have used different AKI definitions like Akin, Rifle, Gedigo. They have not used the denominator in some of the studies. But what is matching? Matching is that the incidence is almost matching the data of global. So incidence is almost 30 to 40% in Indian scenario as well. Now coming to the topic of the renal replacement therapy, and I will start with case. This 40-year-old 70 kg male patient admitted in ICU due to severe gallstone induced acute pancreatitis. Patient has severe acute abdominal pain for last 2 days and decreased urine output for 1 day. Patient was resuscitated with 4 liters of the balanced crystalloid, and that is guided by the dynamic indices of fluid responsiveness. Patient had given the appropriate antibiotic and ERCP is being planned after the initial stabilization. At 14 hours of the ICU admission, the heart rate was 135, BP is 106 by 67, patient on NORID, SpO2 is 95% on oxygen support, and bedside lung ultrasound showing the bilateral pleural effusion with basal atelectasis. What is most important here, the urine output in last 2 hours is only 5 to 10 ml per hour, and positive fluid balance was 6.8 liter. Investigations showing that urea is 118 milligram per deciliter, creatinine is also high 3 milligram per deciliter, potassium in rising trend 4.8, EBG showing the metabolic acidosis and hyperlactemia. Now in such situation, what will you do? Then you have to ask from yourself, what stage of AKI is he in, whether in stage 1, 2 and 3. Will you start RRT now, or you just want to wait and watch, continue observing him? And if you have decided to start RRT, then which RRT would be the best modality for this patient? And if you have started, then how to optimize the RRT delivery? There is no confusion regarding the emergency dialysis. We have to start dialysis whenever the patient has the refractory hyperkalemia, refractory metabolic acidosis, patient have the uremic complications like encephalopathy, pericarditis and bleeding. Patient is resistant to resistance pulmonary edema, that is resistant to the medical therapy like diuretics, and if the patient has ingested some toxin which are dialysable, you can definitely go for the emergency dialysis. But situation like this, it is very difficult to decide as the patient has no emergency life-threatening indication. Then when to start the RRT, whether we should start now or we should wait for some period. Definitely there are certain benefits of the early RRT because it will achieve the homeostasis as soon as possible by clearing the solute and fluid, improving the immunomodulation by the convective removal of the inflammatory markers and cytokinins, and finally because of the reduction of the cellular dysoxia and cellular edema, it will not do any organ dysfunction. But certain inherent risks with the early RRT as well. There is complications related to the vascular access. There will be chance of the hemodynamic instability as we don't give any compensatory time. So there will be chances of delayed renal recovery and definitely the cost will be high. So to address this debate, a lot of trial has been done. And the first trial, a major trial published in 2016, one in JAMA and another in the NEGM, and both are contradictory. Elaine in the favor of early initiation of RRT and Ekiki not in the favor of the early initiation of RRT. Why Elaine in the favor of early initiation of RRT? Because they found that there is definite 90 days mortality benefit when we will start RRT early. But there are certain limitations with these studies. Small sample size, the single center studies, and mostly done in the post cardiac surgical patient. And they have started the RRT too early, within 8 hours of the stage 2 AKI. In AKI, this is the multi-center, sample size too good. They have started RRT after waiting for some period, within 6 hours the category stage 3 AKI. They found no mortality benefit. So, as per this studies, depending on the multi-center, good sample size, we can see it is better reliability compared to the Elaine's trial. Later on, two trial has been published, the ideal ICU and start EKG trial, and both has shown that there is no mortality benefit at 90 days if we go for the early initiation of RRT. Till that time, it is very clear, don't go for the early initiation of RRT, but we have to wait for some time. How long we have to wait for that? So this question has been addressed on EKG 2 trial studies. That is the follow-up study of the EKG, and this is a multi-center sample size, not 278. They have divided the studies in two arms. One is the standard arm and another is the more delayed arm. In the standard arm, they have started the RRT when the patient in the category stage 3 with the oliguria of more than 72 hours and blood urea nitrogen is 40 to 50 millimole per liter. And they have started within 12 hours of this inclusive criteria. And in more delayed arm, they have started RRT when the blood urea nitrogen more than 50 and patient has the life-threatening complication of AKI. And again, they found that there is no mortality benefit even after waiting so much time. So it is very clear that we can wait for some time before starting the RRT. So on the basis of this trial, like EKG, ideal ICU and start AKI, there is definitely no mortality benefit. Align in the favor, but some limitations. EKG2 trial gives more better answer that we can wait for some times, but more delayed appears harmful. So now the time to move from preemptive RRT, it has certain advantage, but on the basis of trial, better to move from preemptive to delayed approach. Now, is there any role of loop diuretics in patient with AKI for initiation of RRT? This study has been published, that is the FST trial in the critical care, and they have given the furosemide in 162 patients, and 44% responded with the furosemide dose, and only 6% received the RRT out of 44. But see here, those patients who are not responded with the FST, they have randomized into the two arm in the early RRT and the standard RRT. In the early RRT, when they have started the RRT within 6 hours of the FST non-responsive, and out of 58%, 57 required the RRT, and here in the standard RRT, 60% included in this arm and 45 received the RRT. So you can see here the non-responsive conditions in the both groups, most of the patients require the RRT. Hence, if the patient is not responding with the FST, you can think about to start RRT. And what they concluded that the FST may be used as a tool to predict the progression of AKI and need for RRT, although larger RCT are required. Now, so this patient in the category stage 2, so whenever any patient either in the category stage 2 or 3, then see whether the patient has the life-threatening indication or not. If yes, definitely go for the renal replacement therapy. If no, then I adequately hydrate the patient. Avoid overhydration. Hydration should be guided by the dynamic assessment of the fluid responsiveness. Maintain or achieve the mean arterial pressure as soon as possible and cardiac output as well. Avoid the nephrotoxic drugs. Detect and treat the post-renal AKI as soon as possible. Reassess the patient frequently. Even that if the patient has the life-threatening indication, then go for the RRT. If no, then ongoing dynamic assessment of fluid responsiveness has to be done. Maintain the adequate map, ensure the euvolemia, and wait and watch up to 48 hours. Go for the individualized approach depending on the trajectory of the patient's acid-base balance and the electrolyte levels. Or either you can go for the Furosemide stress test. What is this? Always select the appropriate candidate by seeing that patient is adequately resuscitated. Patient, if after that even that patient has the persistent oliguria, you are in doubtful situation that fluid vasopressin eye drop challenge would help. Give the furosemide in the furosemide naive patient at the dose of 1 mg per kg IV bolus. Not respond patient who already received some amount of furosemide, in that condition you have to give at a dose of 1.5 mg per kg IV bolus. Wait for 2 hours, see the urine output, it is more than 200 ml or not. If yes, then patient passed this stage, patient in the peritoneal oliguria. If no, it means patient is not passed this stage and patient might have the intersegment peritoneal failure, as patient may need, or patient definitely may need patient renal replacement therapy. So you address these two questions. Moving to the third one, which renal support? These are the acute renal support in the ICU, continuous replacement therapy or peritoneal dialysis. This is the prolonged intermittent renal replacement therapy or slow low efficiency dialysis and intermittent hemodialysis. So in this CRRT, as it will be start with the low blood flow, so there will be the better hemodynamic stability, and as well as there is minimum fluctuation of the ICP, so it will give the stable ICP. So whenever any patient who are on high vasopressor dose and patient has the sign of raised ICP, better to go for the CRRT. I will not discuss about the peritoneal dialysis because it is not useful in case of the acute setting or in ICU setting. But definitely certain advantage of CRRT in terms of the hemodynamics and stability of intracranial pressure, but it is also associated with risks of infection and it is prolonged therapy, so there is chances of immobilization. ISD, yes, rate of fluid removal is fast, rapidity of the correction of the metabolic and acid waste, but there is risk of the osmolar shift, so it will causes the disequilibrium syndrome, not useful in those patients who has the raised ICP. What are the molecular transport mechanisms involved in different modalities of the RRT? Ultrafiltration, it is removal of fluid across the membrane along with the hydrostatic pressure. Second one is the convection, the solute removal with the fluid flow, that is a solvent drag. So this for this ultra-filtered fluid, we have to replace that, either pre-filter replacement fluid or post-filter replacement fluid you have to give. Third one is the diffusion, there is passive movement of the solute along the concentration gradient. Fourth is the adsorption, where solute is removed by adsorbing the surface. So this is the adsorption. Mainly use the hemoperfusion. Now, what are the modalities of the CRT? So this one is the first one is the slow continuous ultrafiltration, where there is no solute clearance, only the fluid is removed, indicated in case of the congestive heart failure, not responding with the medical therapy like diuretics. This is the continuous veno-venous hemofiltration. So solute clearance is occur. Method is the convection, and as there is removal, solvent drag is occur, ultrafiltered fluid is also removed. So that has to be replaced with the replacement fluid, either the pre and post dilution. Third one is the continuous veno-venous hemodialysis. So here diffusion process is involved, solute is cleared like urea, potassium, then operative fluid is required. Here is the dialysis. Continuous veno-venous hemodiafiltration, both process involved, diffusion as well as the convection, solute is cleared, middle molecule solute is also cleared, and as both method is involved here, so both fluid is required, dialysate fluid as well as the replacement fluid. Now the question is, which form of RRT should we use? First one, always you think that what we want to remove from the plasma. You want to remove the small molecular electrolyte having the size is less than 500 Dalton, like urea, creatinine, potassium or lithium, go for the dialysis or filtration. If you want to remove the middle molecule, like larger drugs, vancomycin, again, then in that condition, the convection is has certain advantage over the dialysis. Low molecular weight, like cytokinins, complements in sepsis patient, better to go for the convection method, hemofiltration. Or if you just want to remove the water only, then go for the filtration methods. Always take care of this point also. See the cardiovascular status of the patient on the vasopressor support. If patient on the vasopressor support, then how much drug he or she required to maintain the MAP, the availability of resources, the experience, this is most important, clinician experience, and other specific clinical consideration like septic shock, raised ICP and hepatic encephalopathy. In these conditions, continuous veno-venous hemodiafiltration will be helpful. If we compare the data SLED versus CRRT, a lot of study has been done, and there is no outcome benefit of the CRT over the SLED, but definitely whenever the patient has the sign of raised ICP in that condition, or patient on the very high vasopressor support, in those conditions better to go for the CRP. In all other conditions you can think about the SLED. Now the next one is the how to optimize the CRT delivery. So these are the basic component of the CRT system. You all know these are CRT machine, hemofilter, solution, different type of the solution, anticoagulations, vascularization, blood warmer. Is how to prescribe. So decide modalities, which modalities you want, as I have already discussed. What will be the effluent dose, anticoagulation you required or not. If required, then systemic original and replacement. This is the typical CRT prescription. Filter AN69 M100. Prescribed dose 25 to 30 ml per kg of effluent volume. Target dose 20 to 25 ml of effluent volume. And these are the blood flow, pre-dilution, post-dilution, replacement fluid, dilated fluid rate, patient fluid removal, anticoagulation, whether heparin or renal citrate or none. Filtration fraction, always keep the filter fraction less than 20, not more than 25. Go for the zero balance or negative balanced CRT. How to wean? Has the intensive kidney function improved? You look for that. Has the disorder that prompted the renal support is resolved or not? And is continuing the CRT consistent with the goals of care? So this guide, I-System 2021 guideline says that do the careful assessment of the volume assessment, acid base and metabolic parameters. Monitor the blood gas. If the pH is more than 7.20 in 2 consecutive readings 1 hour apart, then you can think about the to stop the CRRT. Urine output more than 400 ml in last 24 hours, you do consider. Switching over to the other modalities like SLED or ISD if the patient is totally hematologic support or low dose of vasopressor. Stop CRRT if the filter clots, that is the unplanned events. These are the complications associated with the CRT related to the vascular SAS or extracorporeal circuit. With the anticoagulation, certain electrolyte imbalance may occur, neurologicals like dialysis, discology syndrome, and other complications like nutritional loss and so on. Take care of the nutrition during the RRT. Always remember in CRRT the protein requirement will be 1.5 to 1.7 gram per kg. Take care of micronutrients as well. Drug dosing, very important. Loading dose should be adequate. Maintenance dose, either you can increase the duration of drug administration or reduce the drug. And you have to follow this for deciding the drug therapy, preferably given after the dialysis. In case of the CRT, the creatinine clearance you have to take is 10 to 30 ml per minute. This is the Prismaflex machine mainly we have, that is give the different therapy. CRRT modalities are SCUF, CVVS, CVVSD and CVVSDF, therapeutic plasma exchange, hemoperfusion, CRT with the Mars. Prismax 2 system has the ECOR as well, so it will be helpful to remove the CO2, that is the extracorporeal removal of the carbon dioxide, mainly in case of the severe ARDS patient who are on low tidal volume ventilator strategy, and if the patient will develop the hypercarbia, that will affect the pH. Therapeutic plasma exchange we can do. Hemoperfusion also we can do on the basis of adsorption principle, and these are the toxins amenable for the hemoperfusion like lipophilic drugs, barbiturates, anticonvulsants, anymore, paraquat as well. Mars, it will helpful for the bridging therapy in the treatment of liver failure as a bridge to the liver transplantation. This is the Mars treatment kit along with the CRT machine. And incidence of AKI in patient with ECMO is very high, 70%. So about 60 to 70% of patients requiring ECMO need RRT. So whenever you are planning for the ECMO, you should have the CRRT machine instant. So to conclude my presentation, this is most important message I want to give. Whenever you are planning to start new ICU, then always provide the infrastructure for the RRT unit or extracorporeal blood purification unit in ICU. Now it's time, because a lot of patients will develop the AKI we have already seen the incidence as well. We have to start the competency in education program in the renal replacement therapy, mainly the CRT technician program, ECMO technician program, and we have to develop the RRT team. This is a need of the hour, along with the nephrologist, intensivist, senior technicians, CRT technicians, as well as the nursing officers. Thank you so much. If you have any questions, you can mail me. I have written my mail in the first slide. Thank you so much once again.